This is Dr. Ben Pearl. I'm a podiatrist in Arlington, Virginia, and today's topic is going to be tools for the athlete, from motor mapping to Pemf, or pulsed electric magnetic fields. We're going to start first with just some simple biomechanics, looking at the big levers that move the foot and leg, and then we're going to move on to pulsed electric magnetic fields, motor mapping, why things will stimulate and improve after injury when we add interventions, and then wrapping it up with some things that will improve our practices and our patient outcomes. Shoe fit, shoe options. We're gonna have some fun going over some metrics with shoes and talk a little bit about some shoe metrics with injuries. First thing, the most important thing, and since this is called Fit Foot U, we're gonna be talking about shoe fit. Most of us buy our shoes too tight, whether it be a dress shoe or a running shoe. What I like to think of this, when we use the fitting devices, I like to think of, why not use a Brannock device, like we measure the length of the foot, for the internal fit of the shoe. So this is something that my colleague Golden Harper, who's designed one of the zero drop shoes, came up with. He said, why not use one of these correct toes as a shoe fit device? What do we mean by that? Well, let's take a look at the typical shoe insert. If we have our foot in here and it is too tight, when we put this shoe fit device between these correct toes, it will expand out the toes. What's the purpose of that? Because we want to have room for circulation, room for swelling in the foot, and particularly if we start having deformities, injuries that affect the toes, we don't want the toes to be squashed up. So this becomes a perfect device to fit form to the shoe, form being the foot. Okay, now once we have a properly fitted shoe, what are our options in terms of stack height, and what does stack height mean? Well, I'm going to give an example of a brand called Topo, where we're going to go with first a 28 millimeter stack height. And you can see this is the EVA, the expandable material that will compress, and that will give you your ride on the shoe. Now, it is important to recognize that just because something has more stack height does not mean that it's going to reduce the injuries. In fact, there's been nothing corroborated to show that more stack height and more cushioning will lead to better prevention of injury. What we do know, though, however, is let's say I'm recovering from a stress fracture and I have a really skinny mini 4 millimeter stack height. That might be a problem, because now you have virtually nothing between you, the foot, and the ground except 4 millimeters. And that's going to be so flexy that that might be too much for your foot to handle at that particular point. Same might adhere to something where we have too much tension through the plantar fascia, which runs from the heel to the forefoot. Again, if we have a stack height that it is a little more thick, and once you get to a certain degree, it's sort of preference, personal preference and ride. Now let's jump up to a 33. You see it's a little bit thicker. Then we can go all the way to 35. We're adding weight, by the way, with each one of these iterations, okay? But now we have what turns out to be something very, very hard to flex. And what is the purpose of this? Well, it's going to flex when we're running, of course, because we have to toe off. But the advantage of this for someone like me, for instance, where I've bashed up my first metatarsal and have a turf toe right at this joint capsule area between the first metatarsal joint, is that when my toe is propulsing, instead of having something real flimsy, I now have something nice and stable. And even if it has a little arc at the end, a little rocker of sorts in the forefoot, that can also make a better ride for somebody like me. Now, we're going to talk about variations in terms of differential between the heel drop. Everybody talks about what's a zero drop, what's a zero drop? Well, we know that a zero drop has no distance differentiation between the forefoot and the heel. This is an example of an alter shoe. This is an alter paradigm. Now I'm going to show you the same concept with a topo shoe, another zero drop shoe. What's the advantage of a shoe like this with a nice wide forefoot? Well, I'll tell you. If you have a shoe that has a wide forefoot and a zero drop, and I have an aroma, I'd rather be stacked over the ankle, over this joint right here. So that's integral to helping heal some of the common forefoot injuries that we see in a sports medicine podiatry office. They might be an aroma, it might be a recovering stress fracture, it might be a capsulitis of the second metatarsal. It could be all those things. It could be just aching in the metatarsal heads without being a fracture. So there's all kinds of conditions where it might be a little bit better to be a little bit more stacked over the ankle and not quite as high on the forefoot. Now, most commercial running shoes, let's say a Nike, are going to somewhere ride between 12 and 14 on the heel stack height differential. Now we can go up baby steps. This is an example now of going up baby steps where we only have 3 millimeter rise, okay? 3 millimeter rise on this. So why is that important? Well, a 3 or even a 5 millimeter rise, as I have in this shoe, and these are all 5 millimeter rises, just different stack heights. The advantage of doing a 3 or 5, if you've never worn a zero drop shoe, is that now you are not putting too much tension, and here's the chalk talk portion of this, on the Achilles tendon, which is going to insert right here in the back of the heel. So if we have a little bit of a rise, we take some tension off the Achilles tendon. And we also can take a little bit of pressure sometimes off the plantar fascia. Why? Because if we have a little bit of a rise and this structure isn't quite as tight, the Achilles tendon, some of these fibers will cross over from the Achilles to the plantar fascia. So that's one of the advantages of not going all the way too fast to a zero drop. Sometimes it takes a little bit of habituation, a little bit of running before you get the feel for how that ride is going to be, and having some motor mapping internally with your body so your body can get used to it. Now, one of the things that I like to do is I don't like to ride the same stack heights every time I run. I like some variability. So variability with terrain, undulating terrain, maybe not always hills, maybe not always flats, maybe not always banked turns, maybe not always turning to the right in the same counterclockwise direction or clockwise direction. And finally, we can affect the variability with the ride of the shoe, as I mentioned, with the heel drop. So you can go from 0 to 5 to 7, etc. Now, we're going to, in the home stretch here, stay with me. One of the things that we need to appreciate is that forces have different moment arms or different torques at different portions of where the force is directed. So let's say, for example, I've drawn this little model and we're applying force here to the forefoot. Let's say we have ground reactive force at about 700 newtons. Let's say the distance here between the first metatarsal right here and over here to the ankle is approximately 10 centimeters. So we end up with about 700 Newton centimeters or Newton meters as the total force. Now here's the tricky part. If we go closer into the ankle, not as much distance, so the force is not as much. Here we have a longer lever arm, so force directed in the forefoot is going to be an increased force. Over here, we only have about 5 centimeters from the Achilles tendon to the center of the ankle, so less directed force on the lever arm, which means you would have to have a higher force to get the same 700 Newton meters of force. Now, just to make the equation even a little bit more complicated, we're talking now external forces and internal forces. Let's just remember that regardless of what the force is externally from ground reaction, the internal forces on joints are very different than the ground reactive force because there's a lot of moving parts. You have your hip moving, you have your knee moving, you have flexion, you have extension. Now let's add one more element. Not only do you have the hinge ankle joint, but you have the universal subtalar joint right here. So now we've added yet another layer of complexity. The foot has 26 bones. It's a very complex, very marvelous structure, but you can't take an argument that because we have ground reactive force X, that it's going to be the same effect on everything.
Next, we're going to look at movement patterns and motor learning. The Air Force designed an acronym called UDA, which breaks down how we make decisions. This was especially important for World War II pilots. So, the pilot would observe the enemy. Next, they would orient their aircraft to the enemy and get the enemy in their sights. Then they would have to decide when to shoot, all the while deciding on how the altitude was and looking at other factors that are occurring simultaneously. For instance, the tail gunner might be having some problems, or there might be an engine out. The next skill set continuum we're going to look at is precise movements versus gross movements. The first continuum is fine motor movements. So imagine we're throwing a suture. We have to think about moving the swag at 90 degrees, bringing it into the skin, how much pressure we're getting, and then retrieving it. At the other end of the spectrum is gross motor movements. Here we see a gold medal performance by swimmer Michael Phelps in the butterfly. At one end of the continuity continuum, we have discrete movements versus the continuous movements of skiing, where you feel that constant feedback of pressure. Now we're going to review the case of a sural nerve entrapment. To the left of the screen here, we have the Achilles tendon with the surrounding fluid, and right up at the top in that yellow border, we have the sural nerve. We can see the sural nerve is a little flattish, and now we've brought the Doppler in to take a look at the vessels surrounding the sural nerve. Now the sural nerve is still in yellow, and there's going to be the introduction of the fluid to expand the area around the epineuron and the surrounding space, so that now we'll see that the sural nerve takes on more of a roundish shape as the fluid is introduced. This was a case by a colleague of mine, Dr. Gary Ho, and he does a lot of this. And what he's finding is that after he is able to get that nerve visually to a more roundish shape, the function of the nerve improves. Looking at a case of a foot drop injury from an ankle sprain. So sometimes what happens is the peroneal nerve, as it wraps just behind the fibula in the knee, will be traumatized, resulting in a foot drop like we see over in the picture here. Now, what does that foot drop mean? It means that it's very hard to lift up the toes, okay? So what's the reason? Sometimes there'll be a resultant scar tissue that hooks up on the peroneal nerve as it crests around the fibula head up in the knee. And sometimes it's the result of just an engorgement of the nerve. So if there's an engorgement of the nerve, how do we deal with that? What is a way we can non-surgically address that? Well, one way is with something called pulsed electric magnetic field. And what that does is it engages the nerve, it stimulates the nerve, it helps with cell permeability to improve the condition and the status of the nerve, thereby helping to fire the nerve more effectively. We're going to look at an example of a patient that has sustained that foot drop injury 3 months ago. And nothing has really improved it except for the fact that now we are waking up the nerve with the Pemf treatments. I'm going to shift over and segment the treatment that he did, and we'll look at the current state of his dorsiflexion or ability to move the toes upward. So here's the key find. Even though it doesn't look like a lot, my patient was not able to do that last time. I'm going to let you sort of describe it in your words, this wake-up process, what you've experienced from treatment number 1 now to treatment number 2. And we did run it, by the way. We ran that Pemf all the way down to the length of the peroneal into the ankle as well.
So the first time I was here, I could not move my foot at all up, and I felt no control at all of my toes moving up. And when I had this treatment the first time, I didn't have the same sensation that I had the second time. And now I can see, I guess these are tendons like being like activated when I try and move my toes up. But there's not a lot of movement, but this is, compared to what it was last time, this is giving me hope.
Yeah, and that's great. You know, these things, as we mentioned, by their normal healing trajectory can be up to 2 years to heal. So it's already been 3 months for you, and we're hoping that with this jump start of sorts, we're going to shrink that hopefully to just a couple more months. So the real question is, what do we do with frequency? I'm going to suggest we try to see if we can engage this twice a week if possible. And then we'll talk about some other options if it, you know, particularly since we've had some early significant success. I mean, to me, this is like at least about 20% to 25% better than where you were, which, you know, for slogging on with no change is a big delta.
Mm-hmm.
All right, we'll continue to follow up. That does look better. Less of a giddy up for sure. That is good. For athletes that we treat, we have about a nanosecond to treat them. They want to be cured yesterday. So I'm going to show you now a tool called Pemf. It's P-E, pulsed electric magnetic field. These packets of energy come in pulses, just like an MRI when you hear that tick, tick, tick. Now, how did we discover Pemf? How did it all come about? Well, let's look at how magnetic fields work. One of the key observations was by Sir Isaac Newton. Remember when an apple fell? That's about the time we have that apple falling from the tree to get an athlete better, because if we don't get them better soon, they're off to the next doctor, right? So we apply that discovery that he had with the heavenly bodies and the earth and gravitational pull to a therapeutic modality, pulsed electric magnetic fields. So it turns out force equals the G constant, the gravitational pull, with the inverse square, Newton's inverse square law of the radius. So the further we get from the source of what we're treating, it's going to go down by an inverse square proportion. So the closer we get this magnetic field, and I've drawn a Pemf unit, looks just like an MRI. There's copper wire and plastic housing, just like an MRI unit. But in this case, we're not producing an image. We're producing a magnetic field that will influence the tissue and the cells. So what this is going to do to the cell membrane, which is very active, cells have sodium and potassium. So these Na has a charge, and potassium has a charge, it turns out. So what they are doing is they're donating a packet of energy, an electron, which will in turn open up the cell membrane so that helper cells surrounding the cell can get into the cell and repair the cell. Kind of like photosynthesis for plants. We use a packet of the sun's energy to help the growth and natural life cycle of a plant. And in the same way, we can influence nerve, we can influence bone, because guess what? When we break a bone, all right, here's a bone, and we have a little break in it. Bones have calcium, which also has a charge. So when we apply the Pemf unit to that, we can use that energy uptick to help excite those calcium channels which run through the bone, the Havration canals, remember those? And that will help stimulate bone healing at a faster rate. So, what are we talking about faster rate? Well, let's talk maybe 2 to 3 times the normal rate. So for that athlete that was waiting 5 weeks and just slogging along, now maybe we're taking it down to 2.5 weeks instead of the normal 5 to 6 weeks for normal bone healing. And that's assuming that they don't have any risk factors like osteoporosis, or they're not being compliant about wearing their cast or offloading. So this becomes an invaluable tool to making your practice better and making your patients and your athletes more satisfied because we're getting them back in the game sooner. So another thing to remember about Pemf is it's different than your cell phone. It's much safer. Our cell phone is transmitting energy at a constant continuous rate. It's open electromagnetic field. Pemf is in pulses, hence packets. So it turns out when we have pulses, it's much safer. You've heard the talk about not putting the cell phone up to your ear because people are worried about brain cancer. We don't have to have those same types of concerns with Pemf because even though much higher Gauss, which is the level of energy, or Tesla, the power, the only thing we have to be concerned about is the biologic frequencies, because if we get up into biologic frequencies greater than 60 to 80 hertz, if we get up to frequencies greater than 60 to 80 hertz, that could potentially cause free radical damage in the cells that might lead to damage down the line. So as long as we know the operating space that we're in for safe levels, we can safely deliver pulsed electromagnetic fields to help cure our athletes.
For this last segment, we're going to take a look at some amazing things that happen with our neurocircuitry. Let's take the example of someone that has had an injury that has limited them from partaking in normal walking or even being able to grip something with their hand. As we see in this short 60-minute segment, there are now neural implants that literally will fire those missing motor connections in our brain to be able to affect a movement pattern.
The ports in his skull communicate the brain's intention to a robot arm, and then the sensors in the robot hand send the feeling of touch back into Embry's brain. We also met a young man named Austin Beggin. He became a quadriplegic after diving into a submerged sandbar, but now he's involved in some of the most fascinating research that we saw while shooting this story. Like Scott Embry, he has ports in his skull that connect to his brain, but unlike Scott Embry, the signals for motor control go not to a robot arm, but to his own arm, to sensors inside his arm that fire his muscles. This allowed Austin to do something that he hadn't been able to do in years, and that was shake his father's hand.
You can definitely feel the squeeze.
Yeah, I got a good grip of it.
Yeah.
I mean, it was the moment that kind of summed up to me why I even did this.
In summary, we looked at some principles of biomechanics and motor mapping that I hope improve your patient outcomes. We looked at motor mapping that is impaired by injury, and then some interventions that we can do to improve the motor mapping and the actual range of motion and functional capabilities of the patient. Two of these were Pemf and hydrodissection, and then finally we wrapped up with external nerve stimulation. Now, it's important to remember that this stuff is largely theoretical and we know a lot, but there is some information that we still don't know. And sometimes we just need to observe, watch what our patients are gaining from the interventions that we're doing, and then adapt from there. I hope that this stimulated some thought, and I look forward to any questions that you might have. You can contact me at arlingtonfoot@gmail.com. For a replay of this presentation, you can go to my YouTube channel at Dr. Ben Pearl, where you will find other related content. Simply hit subscribe, and you'll be in where you can get more of this content and other related information. In addition, I will be hosting a virtual biomechanics summit on January 24th at 4 p.m. Brooks Running Shoes is a major sponsor. We'll be looking forward to having luminaries like Dr. Richard Blake, Simon Bartold, and Golden Harper. The summit will be participatory. Simply email me at arlingtonfoot@gmail.com, and we look forward to a fun evening. Thank you so much.